as well as Matt Longcaric, who is also in health integration here at MHA. Others from the state who will be providing information are Jody Lynch, Deputy Director for Treatment and Recovery, as well as Dr. Afet Kalinch in Treatment and Recovery, Alan Rogers in the MHA Information Technology Office, and Janelle Pecano, who's the Chief of the MHA Licensure and Certification Office. From Medicaid, we have Mary Haller, who is the liaison to MHA, as well as Lynn Lyon, who is the Medicaid State Plan Coordinator. So throughout the course of the webinar, I am certain you will be hearing from all of them, either through the presentation or as part of the question and answer session. As articulated in Director Plauk's recent memo related to health homes, the state has spent a significant amount of time looking at the Phase 1 experience. MHA has been working in conjunction with Medicaid to develop a sustainable payment methodology and establish streamlined, more efficient ways to share information and improve processes, generally speaking, in preparation for Phase 2 implementation. In addition, the state has determined that we must, at this point, focus on those with the highest need in terms of those with significant risk and those with uncoordinated care and those who are the most costly. We need to balance a statewide reimbursement methodology that supports the provision of quality health home services while working within our budget parameters. We recognize that this is not a challenge that rests solely with the state, but this will provide some challenges at the provider level as well. As most of you know, MHA and Medicaid have recently sent revised rules through the clearance process related to health homes. MHA has drafted adjustments to the certification rule. Just real quickly, those changes are related to informed consent for health home services, timeframes for conducting an assessment and developing the integrated care plan, demonstrating adequate primary care capacity, and demonstrating progress toward acquisition and implementation of the electronic health record requirement. We are in the process of responding to the clearance comments. Comments are also being reviewed and responded to related to the Medicaid rules to support the tiering approach and the new reimbursement methodology that we will be discussing today. We just wanted to give folks a heads up in terms of time frames, that the rules must be filed no later than Tuesday, July 16th in order to be able to meet our October 1 target date. This means that the public hearing would need to be held between Friday, August 16th and Sunday, August 25th. We do not have those dates pinned down at this point, but we will certainly provide additional information once the rules have been filed, and we will share the public hearing and JCAR dates once they have been set. So we understand and acknowledge that there are many questions about the tiering methodology and how the rates were established. Hopefully much of that can be addressed this morning. And again, we will be responding to the specific clearance comments through that venue as well. I also want to quickly mention before we get started that we will continue to provide technical assistance on Monday afternoons related to the health home application. These are offered through the MHA Office of Licensure and Certification, and hopefully many of you have been participating in those calls. Additionally, we will be offering subsequent webinars after today related to client enrollment, data exchange, claim submission, and other topics related to health home implementation over the course of the next several weeks and months. So information will be shared on those particular webinars and topics through upcoming Health Home Highlights communication. So if we could switch to slide 2. As we get started, I'd like to point out that this webinar is specific to Phase 2 implementation. While both Phase 1 and Phase 2 providers will have to be compliant with the certification standards as they become effective on October 1st of this year, the two phases are operating under different state plan amendments. We will accommodate these differences for the time being as we work to develop a plan to align both phases in the future. The main differences, and again at a high level, are related to the target population, the reimbursement methodology, and outcome measures. Again, the focus of this webinar is phase 2, and we will certainly communicate and work with stakeholders as we develop strategies to align the 2 phases in the future. Next slide. I already mentioned that we are working with separate state plan amendments for the 2 phases. A second health home state plan amendment was submitted that extends health homes to the remaining 83 counties. That was submitted on June 27th. And again, we are hoping for a target date of October 1 for implementation. But just want to remind folks that, again, that is pending approval from CMS, and we will be working over the next several weeks with CMS to achieve that, hopefully. And then slide 4, please. This slide touches on the goals that were expressed in Director Plauk's communication, as well as what we've learned through phase 1 implementation. We want efficient processes and infrastructure to support health homes, all the way from the provider certification to client enrollment to data exchange. And we want to assure we have the right population participating in health homes in terms of including those in which the service can be most impactful, specifically those with uncoordinated care and who are at the highest risk. And finally, we want to assure that we have established a reimbursement methodology that is sustainable well into the future. So at this point, I'm going to turn the presentation over to Douglas Day to review the focus of the webinar and discuss the acuity tiers and payment methodology.
Good morning, everybody. Our focus today is for the phase 2 health home providers for the upcoming 83 counties. We will go over the eligible population and the acuity tiers. And what we refer to as the acuity tiers is 2 groupings by children and adolescents and adults. And it serves kind of a dual purpose of identifying the cohort of folks who are eligible and then moving those into kind of payment tiers. So we'll get into that, the payment methodology. We have made available de-identified data to help providers who are looking at becoming health home service providers and the application process. Matthew will talk about that a little bit later. And enrollment options when a consumer does meet the service history with more than one provider, and other technical assistance areas. So as I said, this section really, for about the next dozen or so slides, is on the acuity tiers and the payment methodology. Right up front, we wanted everyone to understand that the data set we had available to really look at was the Medicaid claims and encounter information. We utilized dates of service between September of 2011 and August of 2012. That is a calendar year worth of data. And we have been asked kind of why we aren't a little more current with it, and there's a couple of reasons. Is that in the fee-for-service arena, generally Medicaid doesn't look at anything newer, if you will, than the past 6 months, and that's to allow a little bit of run out and lag encounter. So most of the time what we will start with is at least 6 months prior to what we're looking at, and then we picked up the year there. We are planning to do a refresh of the data and the information closer to implementation time. We are anticipating that when we do that, the calendar year of data that will be available for folks to look at that point is April of 2012 through March of 2013. In addition, when we've looked at this, pretty much the population involved here has had continuity of eligibility through that in the 11-plus month kind of time frame. So it's a very consistent population within there. So we've talked about, or mentioning that there's a tiered payment methodology, and for the phase 2 areas, Ohio Medicaid will reimburse health home service providers using a 2-tiered payment methodology. We also then subset that into children, adolescents, and adults, but the tiered payment is the same. And the rate that we have developed for this is based on the acuity of each person's chronic conditions within the grouping of individuals there, their Medicaid service utilization history, and the resource intensity the health home service provider will need to bring to serve their population. Now before we jump full-fledged into the tiering methodology, we have some general terminology and concepts up front. I've mentioned already that we have adult, children, adolescent groupings. And then we will also separate those into an additional 2 categories. We've looked at average total cost for all Medicaid services. That would include physical health care services, pharmacy type of services, any claims that Medicaid pays for, including behavioral health too. We've looked at hospital admissions for all services that Medicaid pays for, again, physical health and behavioral health included there. A visit in our terminology represents a unique client or provider interaction, which is a little different for the behavioral health field. We're accustomed to units. So let me give a little explanation of how we've converted units, if you will, into visits. So if we had a person who received CPST in the morning from Agency 1 and in the afternoon from a different agency, that would count as 2 encounters because the agency is different there. If somebody else received CPST in the morning from Agency 1 and counseling in the afternoon from the same agency, because those are 2 different services, they actually represented 2 separate visits. And Agency 1 and then counseling in the afternoon from Agency 2, again, that would be counted as 2 separate visits in this. We will talk about prescriptions, and when we looked at that information, we did initial prescriptions and refills, so you come up with counts there. And then we also looked at the use of J-codes, which are injectable medications or medications office administered to clients, and we'll show those on the next slide. We have a listing of 6 of those J-codes, and I am not a clinician, so I will not run down through these, but we put these out there so that folks can see what those were that we used in our data analysis when we were looking at the injectables. Next, Heather. Now, you also see where we have used a general grouping of diagnostic codes in our analytics and kind of grouping of individuals. A lot of those diagnoses, and I will again say I'm not a clinician, are really geared toward the adult population, but we did drill down into the children and adolescents to look at who was showing up in the grouping. And even though we had those adult diagnostic categories out there, we did identify that we are picking up many of the children and adolescents through other groupings, and these are the listing of the top 5 diagnosis groupings for the children and adolescents, and you will find that I think there's one, if you can help me, that matches the other categories, but for the most part.
Right. The most disorders are very well aligned with the criteria we have in this tiering. However, the other diagnostic criteria do not seem to align. However, overall the criteria is picking up kids with the kids' typical diagnosis.
Next slide, please, Heather. All right, this is our Tier 1 for adults, their criteria, and we will talk about the case rate in a minute, but as you can see up there, we put the monthly case rate for this grouping is $215 per person per month. And you will see where we have a left and a right-hand columns here, and we'll just run quickly down through these, that our left-hand column were the indicators of uncoordinated care or moderate CPST uses. And as you see as we go down here, there are ORs. So a client or person could get into this kind of filter here, if you will, if their total admissions, hospital admissions, were greater than 1, and their total Medicaid costs were greater than $8,426. Or they could get into this grouping if their emergency department visits were greater than or equal to 4. And when we were looking at this grouping, the mean in there was 3, so we're a tick higher than the mean in here. And they also have the $8,426 in total Medicaid service costs. Our third kind of tiering down in here is if they could get into this grouping if their CPST visits were greater than or equal to 10 during that time frame, and that's the median across CPST visits. We now have in the middle column an and. So if you meet one of these 3, then we go over now to the right-hand column and look at meeting any of these groupings, the first one being the diagnostic categories where we just kind of talked about the children are a little different. And you can see those: schizophrenia, schizoaffective, bipolar 1, other psychotic. If you didn't meet one of those, you could then meet the ODMH service utilization greater than or equal to 9, which was the median across all services, which is a little different than number 3 on the other side. Or we looked at pharmacy or medication usage, which the first level underneath there was if you received the 13 or more prescriptions during the time period from those drug classes, or if you received an injectable during the time period, and that was the preceding J-code listing we had. This again was given to those who demonstrated a need based upon a combination of a history of uncoordinated care and serious mental illness as evidenced through the diagnostic code, the high service utilization, or pharmacy use. Now, there is a little uniqueness in here. On the left-hand column, number 3 is an automatic kind of criteria qualifier for number 2 in the right-hand side. So it gives a little larger grouping of individuals when you drop down to number 3 on the left, because you do automatically get in on the right-hand side. So that's 18 and over. Next slide is our children and adolescent criteria. You can see that the case rate here is still the same. The criteria is actually the same, with the exception of where we put the highlight in there, that the children and adolescent, their total Medicaid cost is set at a lower threshold than the adult population to qualify in the left-hand column around the uncoordinated care or the indicators of moderate CPST use. But other than that, they are exactly the same criteria in there. Now if we move to Tier 2, this is a grouping of individuals with higher indicators of uncoordinated care through their healthcare costs. These individuals will be paid for at a higher monthly case rate. It's $100 higher than the other. You can see that up there at $315 per person per month. This being the adult grouping, what you can see is that our terminology we've coined for it is they are at a super high cost. Can you go back one, Heather? I think we jumped forward one. Thank you. The adults are at the super high cost, which is almost $20,000. You can see $19,300 there, total Medicaid healthcare costs. That is the 90th percentile, so we are really at the high-end grouping. Or we have alternative over here, and then you have to meet the criteria on the right-hand side in those 3 groupings in one way or another, which is general high cost, where you have at least $84.26 in total cost. You also have an individual with an inpatient admission, and we have our criteria here for serious mental health diagnosis and services there. It is the same as the other with the exception of number 2, which is the CPST usage criteria in there. The diagnostic coding is the first criteria, and then in the third is the pharmacy or medication usage there. But again, this is high-end, high-cost folks who are at the 90th percentile and above. Now for children and adolescents, again, the criteria is the same with the exception of the costing bands there. Again, you will see the kids are categorized with super high cost of almost $11,000, 10.6. Again, though, that's the 90th percentile in the children and adolescent grouping. And then we again used in the alternative criteria on the right-hand side where you have to meet all 3 of those criteria, the $5,200 in total costs. And our next one. Okay, that's how we came up with the individuals and did some of our cost analysis. I'm sure everyone's really interested in the tiered rate development. So here will be determined at the time of enrollment based upon the historical data that we'll have available out there. You know, for folks who've been around for a while, this next bullet point we've borrowed from, I think it was a 2007 webinar, that from the provider perspective, you're going to take a number of things into consideration. You know, your cost, which is quantified in our world through the Uniform Cost Report. We still have the Medicaid concept of the usual and customary charge, which is what you charge everyone, for the service. and then the provider concept of sliding fee schedule for individuals who are self-pay or supplemented by otherwise. And then obviously there's the rate consideration, which is a claim adjudication and processing component. Okay. Before I leave that one, right now we are working off of the data set that we have available. There is an intent down the line to upgrade MIT so that we'll match inherently clients to tiers, and there will be more to come on that in future webinars. So moving on to the next slide. In addition to looking at kind of general concept, we did research other states who are bringing this up, albeit a new service, so there's not a plethora of them out there. We consulted with national experts within the health home field and within the national behavioral health field. This is designed to account for the relative resource use for the persons in each of the tier. Obviously, we looked at the historical Medicaid service utilization. That's our 12-month data set. And we also considered input costs, looking at staff salaries, client-to-staff ratios, and administrative costs, including the use and implementation of EHRs. Right. Payment variation, that will actually happen in a number of ways. You know, generally Medicaid operates under, they pay the lesser of the billed charge or the case rate for the acuity tier. So even when we have these two acuity tiers, if a provider bills less, they will get paid the lower rate based upon that. And we did those tiers again based upon their chronic conditions, including diagnosis and service utilization. I'm going to pause for a minute. Heather, let me know we have a number of questions. I've only got one more slide, so once we finish that, we will start addressing those before we move on to Matthew's section here. Now, and again, reimbursement for health home services is considered payment in full for all of the components of the services defined in the mental health services rule, and that includes services that could be reimbursed as CPST. And just as a general resource, if you want to see behavioral health services rates under Medicaid, you can go to the JFS website. They haven't switched it yet, but when or if they do between OMA and JFS, we'll let folks know. But you do have to scroll down to the bottom of the page, and they have both the AOD and the mental health services fee schedules there. So that's the end of this section. We will go ahead and do the questions before moving on to the next one. So bear with us, please. If you would, Heather. I don't know if everyone can see them.
The first question is about the Monday calls, when they are and the phone number and all that. We sent those out. I can probably send it again to the participants today. That helps. Post them on the list. I'll send, if it is, I'll send a link. I'm not sure if it's up yet.
That information was also published in the Health of My Life communication.
Right.
The last several editions have scheduled, and the webinar registration information for the Monday TA webinar.
Next question is there a phase 3? Do all providers interested in becoming a health home have to be part of phase 2?
Because of the geographical implementation, we now just have phase 1 and phase 2. Phase 1 is the, so I was going back to this, consists of the 5 counties being Adams, Butler, Lawrence, Lucas, and Scioto. Sorry. Phase 2 is the remaining 83 counties. So there is no phase 3. There is a little nuance here, though. And because it's the geographic implementation, there are some differences between phase 1 and phase 2. But in general, if you are not in phase 1, your option to become a health home at this point is coming up in the phase 2 that will begin October 1st.
Okay, the next question is, if the client is seen 2 times in one day, same agency, how many encounters is that considered?
The answer is that depends, and that is 2 different encounters at the same agency.
But if it's the same service, let's say CPSC.
I do not believe we counted that as separate because the billing construct, the provider would put it together and submit one claim.
Question, what is the time frame that is being referenced for number 3? So maybe we can go back to the focus slide. We have a couple of questions that are asking what the time period is over the amount, so that might be the same type of question. And these questions were asked during this part of the presentation. If we're not understanding the question, it can also be emailed to the health home box, and we can address it then.
Yes. I think we need to jump to the one in the middle there. If you
Okay. Could you go over the child-adolescent groupings again and where we can find this information?
Yes, the child and adolescent groupings are in 2 of the slides. Again, is Tier 1 and Tier 2. Tier 1 is shown on slide 12. Tier 2 is shown on slide 14. And as I mentioned, the groupings are the same. The only thing we altered is the historical cost threshold. So I'll go through slide 12 again if you would back up to it. Okay. In Tier 1, a child or adolescent would qualify in the uncoordinated care or moderate CPST column if their total admissions to a hospital were greater than or equal to 1, and their total Medicaid cost during the time period, physical health, behavioral health, was $5,200, or if they had greater than or equal to 4 emergency department visits, and they had $5,200, at least $5,200 in total costs, or they had CPST visits greater than or equal to 10. So as long as they met one of those 3, you get a yes on that side. Now we've got to go over to the right-hand side. They would also then need to meet the diagnostic categories listed there in number 1, or have a ODMH service utilization greater than or equal to 9, which is visits, which is the median. And again, that's where I mentioned that if you meet number 3 in the left, you automatically meet number 2 in the right. Or they had high medication usage indicated by 13 or more prescriptions, or the use or administration, if you will, of the J codes that we went over. Tier 2 being on slide 14, this is our really deep end because we pushed up into really high costs here of saying you can get into the high level tier, if you will, by having $10,600 in total Medicaid costs, which is the 90th percentile, or in this case, meeting the 3 criteria on the right, being $5,200 in total costs, having an inpatient admission, and that can be for physical or behavioral health, and meeting the diagnostic criteria or CPST use, or again the medications there. You will be able to have this criteria available. We will publish the slides from the webinar after today's webinar.
Yes. Why are the same diagnoses used for kids and adults?
This is Offset. I will try to respond to this question. I think when this list of diagnoses was created, put together, we weren't really thinking kids versus adults diagnosis. We were thinking, what is the literature? What does the literature say about, chronic, severe, persistent mental illness, and again, the literature that shows health home type services, care management type services that are effective for such conditions within the behavioral health field, with especially the research behind assertive community treatment, tends to show that these are the diagnoses tend to benefit the most or need the most from this type of intensive service. So this list was created based on that literature and evidence-based approach, and it wasn't really intended for adults to be biased toward adults or kids. So that was the rationale behind the list. We wanted to really target those serious chronic conditions within the behavioral health field, with the evidence showing that these are the conditions that benefit the most from a health service like health home service. But we were concerned in terms of whether this was going to exclude or bias against the kids. So we ran an analysis, and the report shows that our criteria, tiering criteria, is diverse and robust enough and balanced enough that it really didn't discriminate against kids. And kids that have other diagnoses or more, typical like behavior disorders, conduct disorders, ADHD, ADD, PTSD, those are the kids that were picked up, as well as the kids with major mood disorders and some, of course, psychotic disorders. So overall, the data analysis shows that kids are represented with certainly diverse diagnosis.
Okay, we have a couple of questions about the patient admissions, what the time frame is for patient admissions.
Can you slide back to slide 6?
The same time frame.
Yeah, as we mentioned, we had to pick up claims and encounters from Medicaid, and as I mentioned before, we accommodate that roughly 6-month lag period. So the analysis that we have done and the population that currently is identified is based upon the claims and encounters from September 2011 through August of 2012. I did also mention that we are looking at doing a refresh of that information. We are going to stay with the 12-month period, and as we get closer to implementation, we hope to have a refreshed, de-identified data set out there, and that would likely cover the period of April of 2012 through March of 2013. So any questions on the time period, please refer back to slide 6 that shows the encounter and claim period that we've been looking at currently.
Okay, the next question is for Tier 2, the high cost. Does that include an IP, or is it the cost plus IP? And does Tier 2 mean that IP has occurred to be in this tier?
I apologize, I got to flip to a slightly larger table myself. I think on Tier 2 you have to look at the left and the right, and instead of an and in the middle, we now have an or. So you can get into Tier 2 if you are in the really high cost band, independent of setting, if you will, for those services. So on the adult population, if an individual had more than $19,300 in total Medicaid claims over the September through August period, they would meet the criteria of being in Tier 2. Okay, let's say we looked at somebody that did not meet that, then we go across to the right-hand column and we look, did they meet at least our general high cost, the average of the $84.26 in total cost? If that is then a yes, did they also have an inpatient admission? That has to be a yes. So the question on an inpatient admit comes when you don't meet. If there was an inpatient admission, then we went through the serious MH diagnosis or high MH service use criteria there that has 3 pieces where you have to meet only one of those 3. But you do have to have a yes for all 3 of those in the right-hand column to get into Tier 2 for adult and for children and adolescents.
Okay, the next question is an inpatient admission defined as medical, behavioral, or either?
An inpatient admission is defined as any inpatient hospital admission that Medicaid paid for, which does include behavioral health and physical health.
Okay, the next question is who determines the tier, is the state or the provider?
For this exercise, because we use the state level data set, it is the state who is determining the tier.
Will will the initial tier always be what is paid per member, even if member gets better or worse, and is moved up or down a tier according to criteria outlined in the previous slide? Or will payment be adjusted based on acuity?
Can you flip over to slide 15, Heather? It's not a whole lot of detail, but right now, tier is determined at time of enrollment. That also would then get into the payment. We are not doing a whole lot of detail right now on billing and payment. We will do that coming up in subsequent webinars. In all likelihood, for the time being, the tier that you hit at enrollment is the tier that you're going to be paid at. But again, we will host a webinar and provide additional details on that in the future.
Okay. It was mentioned that the de-identified client data is available. Where can we get that?
I will defer that one. Matthew plans to cover that in his section, and he will actually pull up the live website and show you how you can get to that.
The 10 or more visits to CPST services, is that based on a year or a less period of time? Is that
again, the time period is the September through August, September of 2011 through August of 2012, and we did, because of the usage of unit billing in the behavioral health system, we did convert visits in those examples I gave before. So if you had a CPST visit in the morning at provider A and CPST in the afternoon at provider A, our billing contract puts those together, so that actually would be counted as one visit because we would see one claim. If you had two separate services, say CPST in the morning and counseling and therapy in the afternoon, even at the same agency, because they were different services, they were counted as different visits.
The next question, this is not a fixed Medicaid rate like all other services.
That's a matter of perspective. I think I would say it is a fixed Medicaid rate depending on which tier you get into. We just happen to have two tiers based upon acuity and intensity of need of the client.
Okay, the next two comments are asking Offset and I to speak up, so we'll try to do that. Does a person have to have received Medicaid services for a year before they can be enrolled in a health home? If not, how can the tier be determined?
Again, I mentioned due to the fee-for-service lag in claims, we don't generally look at the most current 6 months. We are developing a way to accommodate that, knowing that there are clients who may meet the criteria that we have not identified. It's a little trickier, so we will let folks know at a future webinar more of the details on how that will be accommodated.
Next question, will we have to provide services under both tiers?
Sorry, I'm thinking on how to answer that because the answer is no, you do not have to provide them under both tiers. I would recommend you go out and look at the de-identified data after Matthew shares a little bit more about that to see what your current population in this time period is between tiers 1 and tier 2. And you would always have available the ability to do that. I also need to remind people that enrollment for the health home services is based on client choice. So if you offer it to an individual in tier 2 and they accept it, you probably do need to enroll them and provide that to them. But again, I'll let Matt go through the other data set, and at that point I'd recommend you go out and take a look at your information for your agency. How about we just do a couple more, and then we'll get on with the rest of the webinar.
We'll save these questions to take later. For kids, would residential count as inpatient? No.
We have talked about inpatient as an inpatient hospital. So no residential, and I'll use my history with the AOD field. AOD residential, particularly because the services are unbundled and billed a la carte, would not meet the inpatient criteria.
Next question, will there be cost reconciliation on our rates?
No.
Do you want to continue, or?
How about we move on, let Matthew do the next section. Again, we will keep record of the questions, and we will provide answers to them after the webinar. Matthew?
Good morning, everyone. First, we would like to thank the provider community for your patience in waiting for this first cut of data. We also want to acknowledge the significant behind-the-scenes efforts of information services staff at both Ohio Medicaid and here at Ohio Mental Health and Addiction Services to make this available for us today. Their attention to quality control and service has been exceptional, and their work is greatly appreciated. Getting to one of the questions that we just had, to ensure everyone is clear on where to find the provider-level data Excel file on the web, let's try to go there now. Bear with us while we go to the web. And first, you're going to want to go to our new website, which is mha.ohio.gov. And if you will go to the Regulation tab, and then down to Certification and Licensure, and across to Applications. We'll click on that. And under a handful of health home service documents, including the application and the resource document, a link to the June 14th provider training on the application, and then finally a link that is specific to the de-identified data. And if we could click on that, and our IT staff overnight actually created this link directly to our health home page. So you're directed to more information about health homes, and then if we can click on the de-identified data again, you are prompted to open the file. And it may take a few minutes for folks. It may not open now, but I assure you it does.
It appears to be downloading.
Okay. It is a significant file, very large. So as we wait to see that, we can also, as far as the business associate agreement, we're presently awaiting the final approval of that BAA by legal staff, and we do expect to have that available in the coming days. So here too, we appreciate your patience in having that document ready for you. And here we go. This is a look at that de-identified data set. There are 5 tabs at the bottom, and I will walk through those. If we could go back to the slide presentation now. Brief word about covered entities, business associates, and PHI. In general, the protections of the HIPAA privacy rule apply to information held by covered entities and business associates. The increasing adoption of health information technologies has accelerated the potential to combine and use large complex data sets from multiple sources. When data is de-identified, the health information is not subject to the HIPAA privacy rule because it does not fall within the definition of PHI. However, due to potential HIPAA violation of identifying clients, if a provider, as determined by Ohio Medicaid provider number, has 5 or fewer clients that meet the health home service population criteria, their information is not included in this file. The Ohio Department of Medicaid provided Ohio Mental Health and Addiction Services data derived from Medicaid claim information in order to help providers identify their health home priority population. There are a total of 5 reports, as I said, and the claims and encounters encompass dates of service September of 11 through August of 2012. The data presented is for both the adult SPMI and child SED populations and include medical conditions by diagnosis category. You will find that the summary medical data is presented by provider ID number, tier, gender, county. The data reports are also only inclusive of providers that offer the 4 required community mental health services in order to qualify for the health home service. And also, individuals may be counted more than once if having received services from more than one community behavioral health center. And next slide. The 5 reports themselves, we have 2 county aggregate reports, and we have 3 provider level summaries. The county aggregate reports, we have one for the SPMI diagnosis and SED diagnosis. And so too for the provider level summaries, we have one for SPMI, one for SED, and then a third for provider recipient counts. Now that last report, the provider recipient counts, it is unduplicated for a given provider, but may duplicate across providers. The intent of these aggregate reports is to show providers the potential number of individuals that could qualify for the health home service. Next. Here we see a screenshot of the SPMI aggregate by county report, which is tab number 1 on the Excel file. A point of clarification, the columns you'll see by the arrow there labeled CPST visits, those numbers are indicative of visits and not client counts, just to clarify. And as you look at this screenshot, we see columns that indicate numbers of visits for a range of unique medical conditions by diagnosis. Also included is a column to indicate high mental health pharmacy use with 13 or more prescriptions during the 12-month period. For that, you would need to take a look at the Excel file and scroll all the way to the end because it is quite lengthy. At the end there, you'll also see a column for inpatient admissions, emergency department visits across that 12-month period. Next. This next slide is again, keep in mind that the columns indicate visits and not client counts. One difference you may notice between this report and the SPMI report is that it does not include the same number of unique medical conditions as the SPMI. There are just a few less, and that was due to one of the data limitations that we had. Next. For the first provider level summary, this is just to zoom in on it for you. You can see that it's broken out by provider ID. And if we take this case, in the circle, we have identified 4, and they are all Tier 2 patients. The first arrow you see, it's 44 CPST visits, and then the second arrow, we have a column that will, a column and row that will indicate the total number of CPST visits for that provider. Next. So too for the SCD population, you can go ahead and zero in on specific provider IDs and crosswalk it and see what your counts look like. And you can also go all the way across and look at the look at the unique medical conditions diagnosis counts as well. And next. And clarification quickly on the reports. The previous 4 Excel reports were specific to county-level data. This final report that we will look at takes a look at the counts related to historical provider-client associations. We also want to emphasize that these data reports should not be interpreted as cases assigned to specific providers where the clients are or should be enrolled. Next. The provider recipient count report is an unduplicated by provider count of the number of Medicaid clients that meet the health home criteria. Keep in mind that this is a 12-month historical look back at provider-client associations. For the health home service, providers need to be aware that you'll be providing outreach to health home eligible consumers, and will be going through a referral process for individuals with whom you may not have a service history. This rather circles back to the intent of the de-identified data reports trying to give an indication of the potential number of individuals in your consumer population. And a note too about the provider level summaries. There are brief data notes positioned at the top to assist with your interpretation of the numbers. So we will be happy to take questions about those once you have a chance to look at your own population data. And for multiple provider service history, in cases where a person has received services from more than one community behavioral health center, each CBHC will be able to see the total number of service contacts of your clients for the 12-month period, but will not see the service level information of a client's other CBHC contacts. And as was stated before, this is but one webinar in what will probably be a cohort over the next several months to talk about phase 2 implementation and how we are going to approach the details going forward. And stay tuned on our website for updates. Stay tuned for updates and Health Home Highlights editions. We also hope to improve our website to make it as user-friendly and valuable to you as we can. So with that, that sums up our webinar today, and I think we can go back to the questions.
Okay. If the client shows up as receiving service from 2 different agencies, how do you determine which one enrolls the client?
Hey, this is Doug again. We did not specifically address enrollment procedures yet. As we've discussed or shared, we'll be getting to that in subsequent webinars. But in general, you know, a client that is associated with 2 agencies is enrolled when they choose to be enrolled with either one. And it's not, I think what you need to look at is the client population that is shown in these de-identified data sets. I would not, and that enrollment would be based on meeting the criteria and the service being offered to them and the client choosing to accept it. So there isn't anything to say that they, I mean, Matt mentioned this before, this isn't intended to say they, quote unquote, belong to any one agency, but it really is the service. The client has indicators that the health home service will reduce their uncoordinated care, reduce their overall health care costs, but it really is based upon when a provider offers it to them.
Okay, next question. Can a person be enrolled in 2 different health homes? can parents be enrolled in a different health home than their children?
An individual cannot be enrolled in two different health homes or enrolled with two different health home providers at the same time. They can switch that if they choose to. If you have a family unit, let's say a mother and a child, they could be, each of them, enrolled in a different health home at the same time because it's a client choice issue.
Is the provider level summary data broken down into children and adults? Otherwise, it would be hard for providers who treat children to determine the client base.
Roughly it is, not necessarily by age categorization, if you will, but by the SED and the SPMI groupings.
Next question, does the summary report display state hospital admissions?
The answer to that is it only displays Medicaid claims, so no.
Actually, a small qualifier. We have talked about this. The caveat is it displays claims paid by Medicaid. So to the extent, isn't it the individuals over 65 who are in the state hospitals could possibly have it, but it is whatever was paid by Medicaid.
For providers serving multiple counties, is the data sorted by provider by county?
Yes, it is. If you take a look at the data sets, you will see by provider ID in the columns, you will see multiple counties for some providers.
Okay, the next question is about slide 25. I'm going to go back to that. You said they were visits, but then there was also something about specific client visits. I'm not sure if that's a question clear. Yeah, I'm not sure we're understanding that question, so maybe it's something that can be submitted to the email. Next question is, why would you use only past utilization data and diagnoses to determine what service level people need when we know we have not been providing the best mixes of services? This is even more critical when there is a systematic diversity within the larger group, including groups of persons who are high users of services. ODMHAS. Okay. I think that, using information based on claims is helpful in terms of understanding folks' utilization, and again, wanting to get at those folks that have the highest utilization that are at risk, and being able to use that information as indicators of uncoordinated care. That doesn't necessarily mean that that would be the only way that someone could get enrolled or participate in health homes. And I think Doug mentioned that we are working through processes to be able to address exceptions to that, and we will be providing that information subsequently or following this webinar. We have a couple of questions about how to access the location of the Excel data. So I could just send a link to the group for that if that's helpful, or we could go back and show them again.
We can try to go back to the web one more time, and we can also email the file to folks. The link. The link. Yeah, the link to the file. So if you start out at the Ohio MHAS website, which is mha.ohio.gov, and go to Regulation, Certification and Licensure, and at the drop-down box, go to Applications. And on this web page, you will find several health home documents, and the de-identified data is within that. If we select that, we are directed to the health home section of our website. and we have the link to the file here. And again, due to the size of the file, give it a minute or two to upload to your computer when you open it.
I think you might have already answered this. What is the source of the de-identified data?
As we shared back on slide, let me pull it. Slide 6. The data source is the Medicaid claims and encounter data for dates of service September 2011 through August of 2012.
Okay, next question. Can a Phase 1 provider provide services to clients who do not reside in their county? If so, are they restricted to the Phase 2 rates, or do they use their already established higher rates?
A Phase 1 provider may provide the health home service to clients who are not from your home county. You can provide them to any Medicaid-eligible individual, and you will be paid at your Phase 1 set rate. Again, we need people to understand Phase 1 providers are going to be paid according to the state plan amendment requirements that govern those 6 counties. 6? 5? Thank you. And the tiering payment is used for the remaining 83 counties for any provider that comes on board in there. The geographic restriction is by where the provider is located.
The next question is, remind me of where the discussion is regarding youth who are enrolled in an intensive home-based treatment program like MSP. How does this impact health home enrollment?
Again, I think Tracy also mentioned that we are in her memo of June 25th that we are still working through. She mentioned specifically assertive community treatment and working through the model for assertive community treatment reimbursement methodology. The same would hold true for intensive home-based treatment services. So there will definitely be more to come on the status of where we are with both of those particular projects in the near future.
If the client is enrolled in a health home, can a different agency continue offering CPST?
No. Enrollment when a client is enrolled in a health home, it blocks payment for all CPST services.
What does the provider ID number reference? Is it the Nexus number, federal ID, or ODMH certification number?
The provider ID that is in these tables is actually a provider's 7-digit ODJFS, OMA now, pardon me, Medicaid provider ID.
Was consumer and family member input sought and taken into consideration in the determination of this methodology?
In developing the criteria to identify individuals with high levels of uncoordinated care, the departments have worked through a public process, including the rulemaking process whereby individuals can submit input. So we've run it through our open kind of public process. We've made now this de-identified data set available. Anyone is more than welcome to look at it and provide feedback on it.
Next question, how frequently can a patient change health homes or opt out and then in again? Are they locked into a decision for a specific period of time?
Yeah, and because this is covered as a state plan service and free choice of provider, a patient or a client can change. There are no limitations, if you will, other than the inherent limitation that once a health home is paid for a given month, they won't switch and get paid by another one in the same month. Yes, please.
Okay. If the only IP that will count is those paid by Medicaid, if the client is always at the state hospital for IP and is not billed to Medicaid, then the criteria of IP may not be met on someone, right?
Correct.
Okay.
Next.
No.
Go ahead.
This is landline with Medicaid. This is one of the issues we'll have to provide more information on, because we recognize this is one example of situations where someone may actually meet the criteria but don't show up in our data set. So I think Doug mentioned earlier we would be providing more detail about how to address those situations, but it is certainly both departments' intent to make sure that anyone who meets the criteria the service will be available for them.
And I apologize. My correct was actually just in context of the data set that we're showing. So it does not include that currently. So I apologize for that.
If the mental health state hospital data is not included in determining the tiers, does this skew the data and potentially exclude clients who need to be in a health home?
Yeah, that would be the same answer that Lynn just provided. We're looking into accommodating that service provision line, if you will, the state hospital.
Has it been decided how many health homes will be approved for phase 2?
As a service available for certification under the Ohio Mental Health and Addiction Services Department, there are no limitations. So any provider who meets the criteria, and I believe it's having those 4 core services already on their docket, they are more than welcome to apply for a health home certification.
And if they don't have those services currently, they can apply for certification for any of the services, but that does impact, their data isn't included in the data that's being shared.
The next question is, are there plans for grants or another funding stream to support the transformation that agencies have hoped for?
Agencies always have the ability, and I know that there are a number of agencies that have a variety of different grants and funding mechanisms to support integration and practice transformation. Generally speaking, kind of going into this proposition when we started this a couple years ago, knowing that getting upfront costs paid for and things of that nature, are something that CMS was not willing to accommodate. We believe, the approach to the rate does still continue to provide some flexibility. We, took a number of considerations into the development of this rate, and I think that we've got a slide that Doug covered on that. So we are still hopeful that folks will be able to do practice transformation using a variety of different resources to be able to support their health home initiatives.
And just to also add, the department does plan to have a technical assistance and training strategy for this next year utilizing some block grant dollars. So we'll have some partnerships and do some learning communities for you, and hopefully it will be much more robust than this past year, which was successful. So look forward to that in the future as well.
The next question, how many children will be eligible for each tier?
There are no limitations on who's eligible for each tier. The only limitation is based upon the criteria whereby we poor choice of words, so pardon me, assigned an individual to a tier. So as long as you were in the grouping, we just applied the criteria and attributed you to a tier, but there is no restriction on how many by tier.
The next question is asking to please confirm that total claims does include AOD claims.
Yeah, so total claims, total cost includes services paid for by Medicaid, and that would include the 10 community drug and alcohol services.
The next question is asking for clarification about the requirement for a business associate agreement. Is this needed to access the data?
As Matthew talked us through and demonstrated, the de-identified data in the Excel file is available off the website live right now. You do not have to have a BA to access that, nor do you actually have to submit an application to become a provider. It's open and de-identified and available right now.
This is Mary Howard, but it is our plan after an agency has submitted a health home application and become certified and signed a business associate agreement that we will provide full Medicaid data, including protected health information, client names, client Medicaid IDs, and specific information to those certified health homes. So that's the connection to the business associate agreement, is the access to protected health information.
Okay. How is the department going to educate clients and families about the new eligibility guidelines?
At this time, there is not a direct plan to reach out to current clients and their families of services in the system. Because this is a service that providers will be offering, and because one of the core components of the health home service is outreach, it is really incumbent on the providers who are offering this to clients and their families to look at your own population, apply the criteria, and then offer the service to those who are likely to benefit from it. So I don't want to say it's a provider responsibility, but the functionality is embedded in the health home service itself at the provider level to identify and offer the service to appropriate clientele.
On provider level summary slide, where is there a count of clients by tier in addition to the number of encounters? Or is the count of clients by tier only on a county level?
For this data set, it is only at the county level.
Will the act rate be determined anytime soon?
We will provide additional information at a later point specific to ACT as well as to IHBT.
We have a provider who is not finding their provider ID in the data and wants to know who they would contact to make sure the information is correct.
They email the health home mailbox, and we will make sure that we get a response to you. So if there are specific things, and I noticed there's other questions. There's one specific to a tab in a specific row, that folks I know are out there at this point trying to look at their own data. So if you have specific questions about your Medicaid ID, your specific data, if you could send those to the health home mailbox, and we'll make sure that that gets sent around to the appropriate person.
I'd also encourage people to keep in mind that, Matthew mentioned that to avoid some potential HIPAA violations, if you had 5 or less clients, we took you out of the data set. Because of the service criteria, you may not be showing up in it at this time. So there's a number of reasons why a provider ID may not actually be shown in the data set.
This is Mary Howard, but the existence of a provider ID in the data set is simply an indication of the fact that your agency has served clients who meet the Tier 1 and the Tier 2 criteria during that time frame. That the presence or the absence of your agency's Medicaid ID does not
predetermine your ability to apply and become certified as a health home and to enroll individuals who are in the target population. So it's simply, this is a photograph in time of your agency's history of serving individuals to meet the Tier 1 and the Tier 2 criteria. It's not a predisposition of whether or not your agency will become a health home and will serve those clients.
So I just wanted to loop back around. So the questions specific to your individualized agency data can be submitted to healthhome@mha.ohio.gov.
Okay, the next question is, with all the recent changes, are applications still due August 1st?
This is Janelle again. We have, when we did the provider application technical assistance on June 14th, and if you weren't able to participate, that file is available on the website. Really, it's right under licensure and certification applications. It's the link right above the identified data link. We're trying to get the PowerPoint restored. It kind of went away when July 1st went live. What we have said is that we were suggesting that applications be submitted by August 1st. At the time, we weren't certain of when the population data would be released, but even if it had been earlier, it's a suggestion. We will. We have a work plan in the and licensure and certification to process the application. So there is no due date. And in addition, some providers have indicated they plan to start providing health home service, but maybe not by October 1st. And again, when you make that determination, and you can apply at any time.
As for CPST services, are we speaking of individual service or individual/group services? And then there's a follow-up question, can one agency perform health home and another agency provide CPST group services?
When we were doing the analysis and where we indicate CPST, it would include individual and group CPST services, both variations there. And the follow-up question about one agency perform health homes and another provide CPST, we already mentioned that once you're enrolled in a health home, it blocks payment for the CPST services from any agency.
Can a client change tiers after they are enrolled in a health home, and what is the process like?
Not to defer this too far, but we'll get to that in a future webinar. We're still working through some of the policy level decisions. We did mention the tier in one of the slides is determined at enrollment. One of the likely scenarios we're talking through is that somebody who's enrolled at Tier 2 as the health home service results in lowering the acuity. You should see, looking back at the data, coming down to Tier 1, and we'll look at and discuss how that intersects with payment policies. So we appreciate you bringing up the question. We are looking at it and discussing it, and quite frankly, we are not looking at implementing anything that's punitive to help them actually doing the job that it's there to do and being successful.
Next question is asking if providers were consulted about the new eligibility and rate policy.
As we previously mentioned, yes, this has been through the public process predominantly on the mental health service rule. It is in the public process on the Medicaid rule filing, and prior to doing any of that, both departments do have open process where they consult and seek public input.
The next question, how will a provider of CPST services be notified that a client who has been receiving those services is now enrolled with another agency's health home service so they don't continue to unknowingly provide uncompensated CPSC services?
This is Mary Haller. For the Phase 1 providers, we have built into MIS a screen in the eligibility subsystem, which will be carried over into Phase 2. We can do much more specific IT training once we're a little bit further along in the process. But suffice it to say that you can go right now to MIS when you enter in and look up a consumer's Medicaid eligibility status. Within that is an indicator that will tell you whether or not a client is enrolled in a health home. And so that will be carried over into Phase 2 as we begin to expand the process statewide. So providers just need to make sure that they, when they check Medicaid eligibility for their clients, that they also check to see if the client is enrolled in a health home. And one would assume that if you were already connected to a client, providing them with CPST services, that you might have some knowledge of that client's enrollment in a health home if it's not your own agency.
Just to add to that, we revised our certification rules to clarify and add information around obtaining patient's informed consent. And specifically within the informed consent process, the health home provider has to really inform and educate the patients about the limitations around CPSC services, and also through the provider outreach process, health home providers are obligated to reach out to other providers and inform them and do the necessary care coordination and communication.
Since the purpose of the health home is to increase and expand services to this population as it relates to medical services and health promotion, and this creates increase in costs, especially as it relates to EHR patient registry, how can it make financial sense to provide a health home instead of continuing to just do CPST?
I think that is a good question. I think to some extent we need to separate out and think of health homes differently from CPST. Providers have a choice in whether or not they want to provide health home services. So the choice is, of course, balancing an agency finance perspective with that of, are you now wanting to move into the business of integration? Are you wanting to be able to coordinate the physical and behavioral health care? Are you wanting to go through the practice transformation and provide these services, for your consumers? So, we're not trying to diminish the financing piece here, but it really is a decision as to whether or not this is the type of services that you want to provide now or in the future. So really kind of separating these out, agencies certainly can continue to provide CPST, but CPST is not health home. They're not interchangeable. And we are hoping that folks who have invested in integration over the past several years will take advantage of this and move in that direction.
How can public children's service agencies determine if their custodial children are eligible for health homes?
As we mentioned, the de-identified data set obviously will not identify an individual right now. Coming through the application process, and Mary mentioned this, once the BAA is signed and in effect, we will provide patient-identified information to an agency whereby they could query it to see if a custodial child is in that group. But you have to come through that certification application, BAA signing door to get to that level of patient-identified information.
This is Mary Haller. I just wanted to tag on to Doug to answer. Mark, we can talk at greater length about this and also talk maybe with Crystal or folks from TCSAO. But I would suggest in the short term that the Public Children's Services agencies, if they feel that a child meets the level of chronic disability that we're targeting in the health home service, that they just go ahead and make a referral. Once the health homes are up and running, I think the health homes are going to be seeking referrals from other providers of individuals who they believe meet the eligibility criterion. And as we've talked about before, we are looking for a process to accept individuals who, for whatever reason, we agree should be in the target population, but for reasons of the data set just simply do not meet the threshold that we've set out. So I would say the short answer is have them make a referral and then let the health home go through whatever process we determine is the enrollment process, which we'll talk about more at a future date.
The next question is the provider recipient count potential for Tier 1 or 2 or both?
Both.
What if a person has CPST during the month and before or after during the month is in a health home? How does TMET work?
We've constructed our billing logic in this so that a client may receive CPST services up until the day that they are enrolled in a health home. And then once the person is enrolled in a health home, then they may not receive CPST services anymore. And only for the first month of health home enrollment can the client receive both CPST and health home services.
Okay. How about this enrollment? When the client gets disenrolled in the middle of a month, then can the CPST be provided and paid for?
I think not until the next month. If the health home has billed for that month. I mean, the health home billing is monthly. We will clarify this at a later time.
For either Tier 1 or Tier 2, are there minimum visits per month that are standard?
If they're asking, do you have to provide a minimum number of visits in a month to bill for health home service for Tier 1 or Tier 2?
Nothing's changed from our initial health home program, so you have to provide the service during the month.
Do any children have inpatient hospital stay utilization? I thought this Medicaid service is just for adults.
No. Yes, children have inpatient hospital stays, and the Medicaid service is, in fact, not for adults, except when it is an inpatient hospital that is not an IMD, that it is an inpatient hospital that is would be part of a general hospital, not meeting the criteria of an institution for mental disease. So yes, well, we do see inpatient hospital utilization for children.
But before Heather moves on, people are putting up a number of billing and those types of questions. We are actually going to pass by those because we mentioned we will have another webinar or training opportunity as that develops. So please don't think we're just skipping around on questions, but there are some we are intentionally not going to answer at the moment because we'll move them into the next webinar on that topic.
We have some repeats. I'm just going through them here.
Talk about the tiers. There was one about percentage enrollment. the provider has to enroll a certain number of people that pays in.
Over what period of time may an agency phase in its clients into the health home? Is there a required percentage for phasing in enrollment over the period?
Well, any agency providing Medicaid services can establish a Medicaid patient load, if you will. That being said, I believe, and I'm going to ask the folks in the room to help me, that an agency should phase in based upon their ability to provide the service, i.e. their staffing arrangement and patient load determinations that they've done. We don't establish that at the state level, but it is it is a natural outcome, if you will, of bringing a service up.
Keep going.
I'm seeing a lot of repeated questions here. Okay. Will a crisis service be reimbursed by provider 2 if the client is enrolled in a health home with provider 1?
The current business design and MITS only blocks payment for CPST. So the crisis intervention service provided by a different provider than the health home or even by the health home would be paid.
Does the data include clients who had Medicaid spend down and only had a portion of services paid for by Medicaid?
Yes, but it would only look at the Medicaid paid claims, and as Mary's saying, they would have to trip into the thresholds that we've established also.
How do you identify potential clients for health home services that is currently unknown to the agency, since most families do not know the costs they may have incurred?
We're identifying the client.
Yeah, and I think that is the point of sharing that information, the data, with the individualized health homes. And I know that Doug also mentioned that, in terms of our outreach and sharing, the tiering approach, that we would look to the individual health homes to be able to take a look at their caseload and determine with that information and do outreach and work with the client to make a decision about whether or not they want to be enrolled in a health home.
If IHBC or ACT rates come out, will the criteria for health homes based on CPST utilization change to include IHBC and ACT?
Well, I think that, this conversation today is specific to the target population for health homes, and I think we've mentioned a couple different times that we are going to hold off on, getting into the details of how this particular service fits with ACT and IHBC, and we can provide subsequent information on that.
Will phase 1 and 2 health homes be aligned? In other words, have the same payment methodology and outcome reporting expectations before the ICDS plans go live on 3/1/14?
As Angie mentioned in her opening comments, we are working through aligning phase 1 and phase 2 health homes. We do not have a date established for that right now.
Is the data based on our current clients and their utilization September 2011 through August 2012, or is it based on our clients that we were serving at that time?
The claims and encounter, I think that's what you need to understand. It's claims and encounters between September 1 of 2011 and August of 2012. Dates of service. So we did not start with clients. We started with the claims and encounter to drive down into the clients.
what are the chances of having the start date pushed back?
This is Mary. I think the response to that is that health homes can apply to become certified at any point in time. So if your agency, I'm assuming this is about your agency's start date, we are happy to accept applications from agencies who want to become health homes at any point in time, just as you would apply for any other ODMH certified service at any point in time.
Since DH did not work directly with MIDS until July 1, 2012, how would you identify services provided by mental health services since those came bundled through MIDS?
They are identified because those claims were submitted and paid by Medicaid at the client level. The provider of record the claims were submitted and billed through Medicaid, so they were identified through the Medicaid claim set.
Tell us again what the provider recipient count means. What does the number represent in the SPMI, both 1 and 2 tiers? It seems all eligible clients are combined.
Yeah, the provider recipient count report is an unduplicated by provider count of the number of Medicaid clients that meet the health home criteria.
This is Mary. I would say that we're also kind of skipping around on some of the questions because some of them relate to the rules that are out in the public comment process at this point, and we are actually providing comment responses back to all of the clearance comments that we have received, and we will be doing that in the next few days. So if we skipped your question, it's because it sounded to us like it was related to the rules, and so we'll be responding through the clearance process.
Assuming a Medicaid client is currently receiving CPST services and does meet Tier 1 eligibility, does this mean that the client is no longer eligible for Medicaid paid case management services?
Only if they're enrolled in the health home. Because the health home service is a replacement for Medicaid paid case management services. In particular, CPST.
And one of the things that Aset mentioned earlier, when the health home does its orientation and informed consent with the consumer, part of that is to identify to the consumer that if they want to receive health home services, they won't receive CPST. So the consumer can make the choice, and that's probably the key part of that. It's the consumer who can choose.
So I think that's the same answer to the next couple of questions there. So the 271?
Somebody asked about the 272-71. Unfortunately, they've left the webinar, but it is. Health home enrollment is reported in those EDI transactions for individuals who are enrolled.
Yeah. So if your agency submits a 270-271 transaction to check Medicaid eligibility, yes, that does include health home enrollment as part of that eligibility report. Safety services said that.
Is there an obligation for the agency to specifically offer health homes to all clients identified as eligible?
Client's decision as to whether or not they wish to enroll in the health home, and that should be done in conjunction with the health home who needs to seek that client's informed consent to be enrolled in that health home.
But if under, this is Janelle, if the provider is certified for health home service and a consumer does meet, so the provider is choosing to provide it. As Angie said earlier, you know, it's a business decision. Providers can choose whether or not to be part of health integration. But if the agency is certified for health home service, they have an eligible person under client rights, that person has the right to participate in any more, one or more available appropriate agency services.
Yeah, I think what we're reinforcing is, you know, if you make the decision to pursue the integration and the practice change transformation, you know, it really then becomes incumbent on offering the client to individuals that are eligible for it and then providing it to them when they select that option.
Will MHA generate the BAA to each provider? Does the BAA just cover access to ODJSS Medicaid data? I'm not clear on the BAA.
This is Mary. When you submit your application to become certified as a health home, we will also include in that certification packet a blank business associate agreement that you will also fill out and complete and submit along with your health home application.
There's a few questions about spend down. Do we want to address that now, or is that?
The same way that you manage clients for service now who have spend down. I mean, you need to work with the client to know what their spend down is and to assure that if you're intending on billing Medicaid for services rendered to them, that occurs after they have met their monthly spend down now. The same is true with health home services and CPSC.
We're just kind of going through, sorry for the pause, we're just trying to see, how many more like questions that we've already responded to, so just bear with us for a second. Yeah, we noticed that there are a number of questions related to spend down that really kind of get into the billing realm. So we, again, we'll take note of these, and, you know, part of our training in the past has included in billing instructions on how to think about and how to accommodate those on spend down. So I think that there is some information that's currently available in previous presentations that is available on our website now, and certainly, you know, throughout the next several weeks and months, we'll be providing a repeat and an update of those presentations. So we'll certainly get that information out to folks and let folks know through the health home highlights when we'll be presenting that information.
How long from provider request to MHA for health home enrollment so the provider is told that the person is enrolled in this year?
Yeah, again, we'll get to that in some of the future webinars. Our IT staff, and Alan's here in the room, and he's done a bang-up job on getting this underway. We are working on a web-based method to do that, and based upon our preliminary designs, it would be pretty much a real-time, overnight kind of occurrence.
If the client in a health home goes to jail and the agency continues to visit the client, can they bill for the monthly health home rate?
We have the federal government has a fairly clear policy that Medicaid services may not be rendered to individuals who are in prison, jail, or detention. There are a few exceptions to that. I would be happy to provide an advisory memo that we have sent out to the field earlier this year on exactly that subject. So I don't know who the questioner was on that. If we could stand back up. If you could, well, how about whoever that person was, why don't you send your question to the Health Home website, and we'll respond by sending you back the advisory memo on Medicaid payment, including Health Home services for any individuals who are in jail or prison or detention center.
What happens if there is no health home provider in a specific county? This is most likely to happen in rural areas.
Yes, and we get this question a lot by virtue of, I think, because we've taken a phased approach to this. But thinking about this, there are a variety of different provider types that are not available in every single county of the state. So, you know, it's unfortunate that might be the case, but you know, from a Medicaid perspective, I mean, that occurs with other provider types as well.
You indicated that the first month of enrollment to Health Home, the client can be billed for CPSC and Health Home services. Is the fee for Health Home services prorated? I think we already covered this.
Health Home is a monthly service, so as long as a Health Home service has been rendered to that individual during that month, then the Health Home, the certified Health Home, may bill for the Health Home service. Only during the first month of Health Home enrollment may the client, may the agency bill for CPST and Health Home service. So I think you've got the general concept there in the context of your question.
Is a child eligible for a Health Home on the first day he or she presents at the agency?
Yes.
Based upon the evaluation that you're performing and the menu of recommended services and what the agency is certified, it could be offered to them as soon as they are encountering the service provider.
So we're going to take a quick second here to see if we've gotten any more data questions that have come in, given we are down to, I think, only 10 more minutes of the webinar as scheduled, so give us another quick second.
If we become a Health Home provider, will we get monthly client-specific data to know who qualifies within our agency?
At this point, we are not able to do a quote-unquote monthly refresh of the algorithm that is used to identify the target population. We hope to be moving to that at some time in the future. In fact, we hope to, at some point in the future, actually build that algorithm into NIST So it will be a real-time determination that will be made when a health home goes to enroll a client into their health home, that MIT can actually use the algorithmic logic that we have used, that we went through in great detail earlier in the webinar about who meets the criterion of Medicaid expenditures, inpatient hospitalization, ED visits, diagnostics, etc. Up until then, we will be refreshing that data on a quarterly basis. We may be able to do it more quickly than that, but we are going to have some time lag in that data up until the point that we were able to refresh more frequently.
Okay, I'll take this if any future questions. That was the next question. You have the performance measures. Like this. Yeah.
Has ODMH decided on the number of performance measures, and can providers obtain the current list of performance measures?
Yes, in partnership with the Ohio Department of Medicaid, we revised the new performance measures list for Phase 2. There will be 19, a total of 19 measures, and I believe that we just posted a summary methodology for each measure for the 19 measures on our website, Health Home website, but we will share that information through the Health Home highlights. Maybe in the next couple of editions we'll share that information. Our plan is to do a webinar specifically to go over the Phase 2 revised performance measures, hopefully, before the end of July or beginning of August. But there is information on the website, and more information to come through the Health Home highlights and the webinar.
Somebody asked about recording. Yes, the webinar is being recorded and it will be available.
Assuming that it works. The recording does work. But that is the intent.
The little line is moving, showing us that it's recording, but we'll do a playback, and as long as it's there, yes, we'll get it out there.
Sure. Yeah, there was a comment about posting the memo that Mary referenced about serving clients in a jail and having that posted to the Health Home website. That way everyone is able to access that. So that's how we can handle that.
I'll send that to you, Kevin.
Okay. So I think that we have gotten through a vast majority of the questions. There is a specific question that we did not get to. As we go back through and review the questions, if there was a nuance in there that we didn't get addressed today, as we were scrolling through these live in the webinar, we will certainly provide responses. Want to also stress that we are working on the clearance comment responses. So again, if those weren't specifically addressed, they certainly will be addressed through that venue in the next few days. We want folks to kind of pay attention to the information on slide 30, because that's how you can access information and submit questions. If you think of something after we close out the webinar today, certainly email those questions to healthhomes@mha.ohio.gov. And that will also be the mailbox to submit specific questions related to your data once you've had an opportunity to go out and look at your agency-specific information. Also want to take a quick moment to thank Heather King
who coordinated the webinar this morning and has assisted us in responding to questions, getting the presentation sent out and things posted to the website after the webinar this morning. So thank you all for your participation and for your questions, and certainly look for additional information following this morning's conversation.